Now, to come away from cystine measurements for a bit, let me talk about the last two measurements I want to mention, which is the measurement of sodium and urea in the urine. I don't know if all your doctors do this. I always find these to be tremendously helpful in all my kidney stone formulas, because I can tell you how much salt you eat by how much salt's in your urine. This is a picture I grabbed from one of the little physiology textbooks, which is just to make a point. If you eat 150 milliequivalents of sodium, forget about this representation of the body, you absorb 150 millimoles of sodium, pretty much. And then you excrete it. And you lose it in basically only three places. You either lose it in your stool, as this picture of a colon, you lose a tiny bit there. You lose it as sweat, again, a very small amount, those are sweat glands. Most of it is gone through the kidney. So of 150 milliequivalents that you ate, 140 show up in your urine. And so when I see a patient, and I say, are you avoiding salt? And they say, yes. And I look at the urine sodium, and it's 300. And they say, well, how did that get there? Sodium is an element, right? Your body can't make it. There's only one way it's getting in. That's through your mouth, right? And it's usually leaving through your kidney. So if your doctor says to you, your urine sodium is 300, don't say, I didn't eat salt. Your comment should be, I wonder where it's coming from, okay? Because it's coming from somewhere.
What effect does excessive exercise have?
Well,
Marathon running?
Well, so you're right. If you are excessively exercising and you increase that end of it, I won't see it. But you know what? I don't care. If you're losing the salts from somewhere else and the kidney doesn't have to handle it, I'm not really worried about it so much. Okay? So the sodium can be estimated, and in fact, it's a really useful guide for you because although you may try to do a low salt diet, David's right. Salt is everywhere in the United States. It's hard to avoid it, and you can be trying your best, but you need the guidance to know, are you succeeding? So it's a very useful test. Next slide. And then the other thing is urea, which David mentioned. Urea is a metabolic waste product from protein metabolism. And so the other thing I measure is urine urea. And so in 24 hours of urine collection, I pretty much know how much protein did you eat. And this is data not from Lithlink, but from a different study, showing that in this study where they actually measured and controlled diet protein intake, they showed that the urine urea correlates beautifully with the amount of protein eaten. And there's been other studies that show this. And so if you think I'm restricting my protein, you can measure your urea excretion, and is it appropriately low? I can usually tell my patients what they eat from their urine chemistry. All right? Because what you absorb from your gut leaves the body in the kidney. And so you learn a lot about what people eat. All right, next slide. All right, I just want to make a couple of summary points here. I mentioned the idea that sometimes we see cystine excretion seems to go up during therapy, and I can often get calls about this. And so I view it as there's three things that happen that can raise cystine excretion during therapy. One, the patient is eating differently. They're eating more salt, more protein, therefore they actually truly are excreting more cystine. Happens. The therapy is actually working, and they've improved the solubility of cystine, and what they started with was a falsely low cystine level, and now they have a much better cystine solubility and an apparent increase in cystine excretion. That often happens. And then finally, falsely elevated levels due to drug interactions with the assay. You get put on a thiol drug, the drug interferes with the cystine measurement, and there's an apparent increase in cystine just because the assay may measure the drug now. So all three of those things are possible. It's up to you and your doctor to sort out those problems if they occur. And then last slide. The last slide. All right. So just to summarize, urine chemistries used in the diagnosis and treatment of cystinuria. Point 2 is the point I want to make out of this whole slide. Urine should be collected in a situation that reflects your normal activity and diet. Please, when you do a 24-hour urine collection, do not say to yourself, "Oh, I'm collecting urine. I better do a good job today." You know, when you see that jug and it's, halfway through the day you realize there's almost no urine in it, and you start picking up the pace. You and your doctor want to know what's really going on. You make and it's not even like you're trying to fool the doctor, but no one wants to be criticized. Do it like you really live, because that's how you need to guide your therapy. And that means not only being better, don't do urine collections on days when you know are abnormally bad. I mean, not that I want you to have a lot of bad days as far as diet and activity, but don't do a urine collection on the day you're having your big family reunion. You're going to be eating potato chips and barbecue and all that. You do it once a year. That's not the day to do your collection either. Do it how you normally live. The other thing I want to point out, and I make my patients do this, is I make them collect at work. Everyone loves to do the urine collections on Sunday. Bring it, mail it in, or look like you mail it in, or bring it to your hospital lab Monday morning. No one has to see you with that urine container. You just sit at home. Right? That's not how you live. People think differently at work. You're a truck driver. You don't want to stop and pee. That's when we need to know what your urine chemistries are really like. Do them like you really live. If you're wondering why the urine chemistries look good and yet you're still forming stones, it may well be that your urine chemistries never match your real lifestyle. I've mentioned this a couple of times now. Issues of cystine crystallization and drug interaction with assays need to be considered when you're thinking about results. The urine pH and volume are the key determinants of cystine solubility. That's how you're going to guide your therapy. But I do think that in the best of all worlds, cystine solubility would truly be measured in every urine sample, because it does vary from person to person. Then finally, sodium and urea in the urine, I think, are really valuable guides to help guide dietary therapy, because I think all of us need feedback as to how effective we are with our dietary therapy. All right, thank you, and I'd be glad to take questions.